So, welcome everybody. So just to introduce you all to one another, today we have our dermatology resident friends from Frontier Dermatology. Is that correct, Jacob?
Yes, that's correct. Sorry, I wasn't sure if I was muted.
Yes, and you guys are based in Oregon, is that correct?
Yeah, we're out in Salem, Oregon. Yeah.
Well, so it's like an East versus a West Coast thing. These guys are 3 hours behind us, and we also have our Goodman residents with us. And going forward, I think a lot of our sessions we will be doing together. So I'm really looking forward to it. And once this class is done, maybe I will. It will nice to meet each one of you. Since I'm not going to be able to see you guys in person. So just stay on once, the class is over and, we'll chat for a little bit.
That sounds good.
So it's still a couple of minutes before we get started. You guys can see the screen, right, where it says blistering diseases?
Yeah, we can.
Yes.
Okay, great. So we will be discussing blistering diseases today. And the way I like to approach blistering diseases, and this is a tip even to deal with them clinically, would be to really, whenever you see a blister, try to determine in your head, like what could be the location of the blister. And the location would be based upon its presentation under the microscope, which would be subcorneal, intraepidermal, or subepidermal. So subcorneal blisters are the most superficial, and very often, you may not even think that they are blistering diseases because, they may just appear as erosion and crust. They are superficially located. So even histologically under the microscope, sometimes it is difficult to perceive them as a blister, and we will discuss that. The subtle hint under the microscope would always obviously be subtle lifting of the stratum corneum, or if the stratum corneum is missing. When we are dealing with the subcorneal blister, most often the first thing you want to make sure it is not an infection. Now, there are not a lot of things which I tell you to memorize, but this is one of the slides which I do want you guys to memorize. So when you think about a subcorneal blister, these 8 things should be at like the tip of your tongue. You want to know them. And so you would want to memorize them. The first thing is bullous tinea. The second is bullous impetigo, staphylococcal scalded skin syndrome, pustular psoriasis, AGEP. AGEP is considered to be kind of like a psoriasiform pustular drug eruption, and we'll talk about that. Then you have certain variants of pemphigus, especially superficial variants like pemphigus foliaceus and IgA pemphigus. And then Sneddon-Wilkinson disease, which is a diagnosis of exclusion. So we'll talk about that. To diagnose this entity, you have to make sure that all the other above entities have been excluded. And then lastly, we have very rare diseases, which we generally do not encounter a lot. Pustular dermatosis of infancy. Included in this category are these 3 diseases, which all tend to present with subcorneal blisters with either neutrophils or eosinophils. So this is something that I need you to memorize. Now, the other way to think about a subcorneal blister, and again, you may want to write this down, is it cell poor or is it cell rich? So this is the long way of learning it, which you need to learn. But then quickly, when you are seeing under the microscope and you see a subcorneal blister, you see whether it is cell poor or it is cell rich. So is it paucicellular or is it cell rich? If it is cell poor, the only 2 things you can be dealing with is staphylococcal scalded skin syndrome and pemphigus foliaceus. If it is cell rich, then it's all the other diseases. So essentially, you can see that in this particular category of diseases, staphylococcal scalded skin syndrome is the only entity which will always just present with a paucicellular subcorneal blister, because pemphigus foliaceus can do either one. So this is an important fact to remember and a quick thing to remember, when you're approaching a slide. Now, let's talk about the recognition of these entities, under the microscope. So this is the first example, and you can see in here, this is a subcorneal blister. This is what I was saying, that to recognize it histologically, it's not going to be, first when you look at it, it's not going to be a very obvious blister. But you see here the stratum corneum is lifted up or it's looking dirty. So this is a subcorneal blister which is dirty. Why is it dirty? Because it has all this neutrophilic infiltrate. Especially when it has this marked neutrophilic infiltrate with debris and very dirty looking parakeratosis, the things that you think about is tinea infection. So that would be really important. I have highlighted the tinea for you guys over here using these arrows, and you can see that when you're looking at tinea, these are going to be translucent structures. So unlike tinea versicolor, which first of all, does not incite any inflammatory response and is very easily visible through the blue spores and the hyphae, this tinea infection, the classic tinea, is going to produce a lot of inflammatory response and looks like translucent or empty structures. So you can see these hyphae forms over here. They may be cut off in a different angle, so they look like these empty holes in the stratum corneum. So all of these structures, right, one over here as well, this an empty hole structure, this is all tinea infection. So this is an example of bullous tinea. And where do you look for the fungus is right adjacent or within this is called the sandwich sign, when the fungal hyphae is sandwiched between the layers of parakeratosis. So right either beneath the neutrophilic debris or right adjacent to it is where you want to look for the fungus. So this is bullous tinea. Okay, so this was the first infection that you're dealing with. Obviously, if you have done a PAS stain, the PAS stain is going to be much more easy to recognize, right? So like it is, but you're not going to get a PAS stain on your slides. You will have to recognize it just based upon the histology. So this is the PAS stain, and you can see it is nicely highlighting these fungal hyphae in the stratum corneum. Okay, now let's go to the next one. So again, what you're seeing in over here is a subcorneal split, or the stratum corneum is lifted up. This is a dirty subcorneal blister because you're seeing all these neutrophils within the infiltrate. And what you also see in here are bacterial colonies. So this is bullous impetigo. Now, it is important for you guys to recognize how do the bacterial colonies look like, because very often you confuse it with crushed neutrophils. So this is a very nice distinction in over here. So these are all neutrophils. So you can see that these are all collection of neutrophils in here, whereas this is a staph colony. So you can see this nice fluffy colonies of bacteria. They look like little, cotton candy pieces. Sometimes neutrophils will aggregate, and you may again think about it, but this always looks like these, has this kind of a fluffy appearance. So that is the bacterial colony. So you have one over here, this, these are all staph colonies. So this is bullous impetigo. So again, a dirty subcorneal blister with neutrophils with the bacterial colony. So I'm going to show you some more examples of this so that you know how to recognize staph colonies, because this is important, because as soon as you see this, you're pretty confident that you're dealing with bullous impetigo. And notice that in classic impetigo, there is not much happening in the dermis, and even the background epi is not very it's not very spongiotic. It doesn't show any significant change, and generally there is just superficial perivascular infiltrate. Okay, so let's go to the next one. So you can again see in over here, the stratum corneum is lifted up. This one has a little bit more edema and spongiosis. And you can see all of these are the bacterial colonies in there. So you can see these nice round clusters of bacteria. So this is bullous impetigo, and this is all the neutrophilic debris. So that's bullous impetigo. Now, do you always need the bacteria to diagnose bullous impetigo? And the answer to that is no. So, sometimes you may not see the bacteria. So what do bacteria do? Now, these are going to produce acantholysis. So sometimes you may not see the bacteria, but you just see acantholysis. You can still diagnose bullous impetigo, and we'll talk about that really soon, because in that scenario, the differential also includes pemphigus foliaceus, and we'll talk about that. But you are seeing that there are nice bacterial colonies in here, and this is all bullous impetigo. Okay, so let's go to another example. Now, in this particular scenario, this is a very obvious subcorneal blister. So you can see how nicely the stratum corneum is lifted up and you have a subcorneal blister. This again is a cell-rich subcorneal blister because you're seeing neutrophils. So you can see how neutrophils are actively exocytosing into the epidermis. However, you do not see any bacteria. There is some slight dermal edema, but there is no bacteria. So a subcorneal blister which has neutrophils with no bacteria and no fungus, what do you think about? The two entities which come in the differential in this scenario is bullous impetigo and pemphigus foliaceus, superficial pemphigus. And in all honesty, in the absence of bacteria, it can be very difficult to distinguish bullous impetigo from pemphigus foliaceus. They can look very, very similar. So how do you determine? So for that particular instance, so when you are seeing a subcorneal blister with neutrophils, with acantholysis, but no bacteria, it's impetigo or it is pemphigus foliaceus. Either they have to give you some second order question in your second order, some kind of a emphasis in your question to suggest that it is one versus the other, or they give you just one of those two answers. If for some reason they are putting both those things in the multiple choice and there is no hint at the question as to what it is, that can also happen. In that scenario, you want to think to yourself, which is the more predominant finding? Is it acantholysis or is it neutrophils? If it is more prominent acantholysis, then you would favor pemphigus foliaceus. If it's more prominent of a neutrophilic infiltrate over acantholysis, then you would favor bullous impetigo. So like, for example, in this instance, there is acantholysis. You can see that the cells are falling apart, but it is not the more prominent feature. The more prominent feature is the neutrophilic exocytosis. So this would be bullous impetigo, but that distinction can be very challenging. In real life, when we are encountered with this kind of a scenario, and if there is no clear-cut clinical distinction, we will always recommend doing DIF studies to be sure. So this is bullous impetigo with no bacteria. So that can happen. And when I'll show you pemphigus foliaceus, I will show what it means by the acantholysis is really prominent. It is not in this particular scenario. Okay. The next entity that is also really important board-wise. So this is a subcorneal blister again. So you can see the nice subcorneal blister. There is quite a lot of acantholysis, which is involving the superficial stratum spinosum, the granular cell layer, and the stratum corneum. This is what is known as a cell-poor subepidermal blister. So, subcorneal blister. So you can see that there is no inflammation here. It's a subcorneal blister with no inflammation, but with just acantholysis. The differential for this entity would be what we talked about, which is a paucicellular subcorneal blister, which could be staphylococcal scalded skin syndrome or pemphigus foliaceus. This is absolutely without a clinical presentation. This scenario is impossible to distinguish based on histology. So this could be either one of the two. This could be either staphylococcal scalded skin syndrome or pemphigus foliaceus. So you have to look for some kind of a hint in your question as to what this entity would be. This is from a patient with staphylococcal scalded skin syndrome. Now, you know that is, again, a disease caused by Staph aureus, but these lesions are sterile. They are never going to grow out the bacteria because this is an endotoxin-mediated disease. So the culture would be positive in the blood, but not in the skin. It is an endotoxin-mediated disease where the exfoliating toxins A and B are released and they target the superficial epidermis, resulting in this superficial acantholysis involving the granular cell layer and the superficial stratum spinosum, which produces the cell-poor subcorneal blister. So this, in the appropriate setting, could be either staphylococcal scalded skin syndrome or pemphigus foliaceus. So that is important. Now let's come to your next entity, which is pustular psoriasis. Now, pustular psoriasis, the more common presentation of psoriasis is with the classic psoriasiform plaque. So in the next week, when we will discuss our spongiotic psoriasiform interface, the study set, we will see what classic psoriasis looks like. Pustular psoriasis is an uncommon presentation of psoriasis, wherein you get a non-discrete subcorneal blister with neutrophils, and the background epidermis may or may not show the subtle psoriasiform acanthosis. Most often, it does not. What you see is just a very sterile subcorneal blister with neutrophils with variable degree of dermal edema. So this is pustular psoriasis. More important than pustular psoriasis is going to be your pustular psoriasiform drug eruption, which is AGEP. acute generalized xanthomatous pustulosis. So that is a really important board question. It almost always, they love to test you on that. Now, how do you recognize that entity? So in AGEP, what you will see is a subcorneal blister with neutrophils. So the top will look like pustular psoriasis. You're seeing the subcorneal split, but then as soon as you go into the dermis, there is going to be a predominant eosinophilic infiltrate, very easily identifiable eosinophils. So a dermal eosinophilic infiltrate with the top looking like pustular psoriasis because there is subcorneal blister with neutrophils is AGEP. Okay, that is, nothing else will do that. So you can see how there are a lot of eosinophils in the dermis along with variable degree of dermal edema, and then the subcorneal split with the neutrophils. So that is acute generalized xanthomatous pustulosis. So I'm going to show you one more example of that. So you can see in here, there's a nice subcorneal split. This is a little bit becoming intraepidermal here, but it's predominantly subcorneal. And you can see it has lots of neutrophils, and you can all see this dermal eosinophilic infiltrate. So they can give you just a screenshot of this, and this would be diagnostic of AGEP, the subcorneal split with the neutrophils and the dermal eos. So that's what you're looking for AGEP. And then there are plenty of second order questions that they can ask you for AGEP. These patients present with the sterile pustular eruption on an erythematous skin, which can rapidly desquamate. So, it's a disease which you have to get on to the patient like right away. Lastly, we are going to talk about Sneddon-Wilkinson disease. Now, I have skipped pemphigus foliaceus because I'm going to talk about it in your classic intraepidermal pemphigus group of diseases. But remember that pemphigus foliaceus, and we'll reinforce that when we are doing that, it is in the category of a subcorneal blistering disease. So here you see a nice subcorneal split with neutrophils. And this is from a patient with Sneddon-Wilkinson disease or subcorneal pustular dermatosis. But to diagnose this, you have to make sure, number one, so you have to go down your algorithm. Number one, there is no fungus. Number two, there is no bacterial infection. Number three, obviously, it cannot be staphylococcal scarlet skin syndrome, right? Because it is too inflamed. Number four, it's not pustular psoriasis. It's not drug-induced. It's DIF negative because you're not dealing with pemphigus foliaceus or the IgA variant of pemphigus, which will look exactly like this, a subcorneal blister with neutrophils. So this is a diagnosis of exclusion, which is Sneddon-Wilkinson disease. So, when you're making the diagnosis, make sure that all the other entities have been excluded. Even under the microscope, when they're diagnosing it, it's either just one entity in the multiple choice, or if they have more of the other mimicking diseases, and there has to be some clue somewhere in your question which excludes those entities out. So this is Sneddon-Wilkinson disease. Pustular dermatosis of infancy, which was the last one, is more of a thing that you just need to remember. Very often they can ask you without showing a slide, something referring to those diseases. So, I've never actually encountered them under the microscope, but they do come under the category of subcorneal blisters with neutrophils and eosinophils. So that was about the subcorneal blister. So the more important thing is to memorize these two slides, these 8 entities, and then to just briefly remember that it could be paucicellular or cell-rich. And if it's paucicellular, you're dealing with these 2 diseases. Exclusively paucicellular is staphylococcal scalded skin syndrome. Now let's come to your intraepidermal blisters. When you're dealing with an intraepidermal blister, which is by far one of the most common blisters that you will deal with, you have to again think, what is the cause of it? The most common cause of it is spongiosis, which is eczematous contact dermatitis like poison ivy. Included in this cause would also be things like bullous arthropodosol, and we're going to discuss all of this in details. The second cause would be ballooning reticular degeneration, which is, we're going to talk about it. It kind of falls in the spongiotic category, but it is a separate reaction pattern on its own, and we will talk about it. The next entity would be an interface-mediated process, which we did talk about when we were doing the spongiotic psoriasiform and interface diseases, but we will reinforce that. So it's epidermal necrosis that has produced you an intraepidermal blister, which could be seen in conditions like bullous EM or Fixstruck, Steven-Johnson, or TEN. So we'll talk about that. So all these first three causes are secondary causes of an intraepidermal blister. But the primary cause of an intraepidermal blister would be acantholysis and acantholytic dyskeratosis. The two diseases in acantholysis are going to be pemphigus and Haley-Haley, and in acantholytic dyskeratosis are going to be Darier's and Grover's disease, and we'll talk about that. Another cause of a true intraepidermal blister is EHK, epidermolytic hyperkeratosis. And then you have rare causes like friction blisters and coma blisters. And then lastly, remember herpes infection. Herpes infection is a common cause of an intraepidermal blister, and we'll discuss that. So this is also a slide. It is very busy, but it is useful if you kind of go through it in broad. Remember, intraepidermal blister, is it a true cause? By true cause, it could be acantholysis, acantholytic dyskeratosis, or EHK. Or is it a secondary cause, which could be spongiosis or an interface change? This is how you broadly remember. And then they love to ask you about a coma blister, though it's not very common, a friction and a trauma blister. So let's go through the causes of your intraepidermal blister under the microscope. Do you guys have any questions up till now? You're good? Okay. So this is, all of you will recognize this entity right away. You can see that there is an intraepidermal blister, and this is accompanied, the reason is lots of spongiosis. So you have fluid in the epidermis and you have dermal edema, and there is this pink inflammatory serum and coagulum, which is produced from all the spongiosis. So this is acute spongiotic dermatitis consistent with contact or irritant dermatitis, which has produced you this intraepidermal blister. This by far will be the most common cause of an intraepidermal blister. So what is the cause here? It's fluid, it's spongiosis. So it is an eczematous dermatitis. Again, you guys have encountered this as well. So here we are on the acral skin, and you can see this is an intraepidermal blister on acral skin. So this would be something like, again, it could be contact or it could be dyshidrosis or pompholyx. So again, spongiosis producing you an intraepidermal blister. This is another intraepidermal blister with spongiosis, and it has a dense dermal infiltrate. When you go up on high power, you actually even see a mini flame figure over here, and there are lots of eosinophils. So this is bullous arthropod bite reaction. So spongiosis with dermal edema and tons of eos is bullous arthropod bite reaction. So this is again arthropod assault with spongiosis being the cause of the intraepidermal blister. So this is again a secondary cause. The next one that we are going to talk about, I'm going to pause this slide for a minute because I want you to basically kind of like imprint the image of this slide in your brain, because this is how it always looks like. And this is what is referred to as ballooning or reticular degeneration of the keratinocytes. So this is a ballooning reticular degeneration pattern, which is very specific for some entities, some diseases. Number one, when you see this disease, you think about hand, foot, and mouth disease, which is Coxsackie viral infection. Number two is your ORF, which is your parapox virus, pox virus infection, which could be ecthyma contagiosum. It could be bovine papillary stomatitis, and I'm missing one entity in there. So there are three diseases, right, which come up in that category. It's slipping my mind. So basically ORF, ecthyma contagiosum, and bovine papillary stomatitis. The third disease it's missing, but it's the same virus which causes it. Hand, foot, and mouth disease, which is a Coxsackie viral infection. So an infectious entity is what they want you to recognize. Most often it would be hand, foot, and mouth disease. This is the most commonly encountered entity in routine practice, ORF being the next one. Monkeypox virus infection can also give this reaction pattern. It can, however, also be seen in acute eczematous dermatitis, such as poison ivy, or in severe polymorphous light eruption. So any severe phototoxicity, including PMLE, will do that. It is also seen in a specific kind of a photodermatitis, which has like racial predisposition, which is your Hydroa vacciniforme. So all those entities are going to produce you with this reaction pattern of ballooning reticular degeneration. And this is what I had highlighted in here. So this is a reaction pattern which you think about ORF, hand, foot, and mouth disease, severe PMLE, irritant contact dermatitis, and hydroa vacciniforme. And there is a kind of a lymphoma, which is also EBV induced. You can forget about that. That's just for completion's sake that I have included in here. So this reaction pattern is that specific. So most of the time when you're recognizing viral infections, like for example, herpes infection, we'll talk about that, you need to see the viral inclusions. However, not in this scenario. This pattern of ballooning degeneration is so specific that you can diagnose it without seeing the viral inclusions. And that is true for hand, foot, and mouth disease and ORF. So this is the pattern. Now, what is this pattern composed of? You can see that the stratum corneum almost always looks acute. But in the epidermis, there is a lot of edema. There is intercellular and intracellular edema. There is so much of fluid inside the cells that they swell up and they blow up like a balloon, leaving behind this lacy reticular outline. So you can see this kind of degenerated keratinocytes, which are filled up with fluid. So there is dermal edema as well as epidermal edema and lots of fluid with almost an acute stratum corneum. That is a pattern of ballooning reticular degeneration, which is diagnostic. When you see this, it is diagnostic of those entities that are lifted. And for your board purposes, they almost always want you to recognize something like hand, foot, and mouth disease or ORF. Okay, so this is a really, really important board question. Okay, so the next one we are going to talk about is your interface-mediated epidermal necrosis. And this is a kind of a concept, again, I discussed in the spongiotic psoriasiform and interface diseases that and this is another kind of like a vignette which you should remember. When you are biopsying a blistering disease, for histology, it is always nice to include a portion of the blister with adjacent normal skin, because the blister is actually old. So sometimes the blister may not show the classic finding, but the story begins at the edge of the blister. And this is specifically important if you're dealing with something like interface-mediated blistering diseases. So you can see nicely biopsied the blister, and right adjacent to the blister, what you see is interface-mediated epidermal necrosis. You can see vacuolar alteration and the death cells, the necrotic keratinocytes. These are going to become confluent, and they are going to produce you this intraepidermal blister with what is known as the lacy sign. So what is a lacy epidermal sign? This looks like a lace. The stratum corneum is artifactually lifted up, and this happens a lot. So sometimes you get confused. You may mistake this to be a subcorneal blister or a subepidermal blister when it is not. It's an intraepidermal blister. So when you have a dead epidermis juxtaposed beneath an acute stratum corneum, that's interface-mediated epidermal necrosis, which is your lacy epidermal sign. When you see that, you're dealing with either bullous EM or bullous Fick's drug or EM major or Stevens-Johnson or TEN. Okay, so you really, between those entities, it's very difficult to distinguish without a clinical information. Now, some people say that Stevens-Johnson and TN may not be that inflammatory, but I do not always find that to be true. It requires clinical path correlation. But the purpose of this slide is to recognize interface-mediated epidermal necrosis, which produces this classic lacy epidermal sign, wherein you have an acute stratum corneum and juxtaposed beneath it, you can see this dead epidermis. So this is an intraepidermal, not a subcorneal and not a subepidermal blister. You can also see variable degree of edema, especially in EM and in Fick's drug. Very often those lesions begin with spongiosis. So you will see variable degree of dermal edema, which may also contribute to the blister formation. Okay, so this is a beautiful example of Stevens-Johnson syndrome. This was actually when I was a resident, and this was an autopsy case of mine. The patient unfortunately died of this particular entity, but it is a very nice, which illustrates the findings that I was telling you. You can see that right adjacent to the blister is where the cell death has begun. And you can see there is vacuolar alteration with all these death cells in the epidermis, and they are becoming confluent. And finally, you have a necrotic epidermis juxtaposed beneath an intact stratum corneum, the lacy epidermal sign producing you an intraepidermal blister. And this is what are you trying to evaluate. The roof of the blister is what you often get in urgent situations where you're trying to evaluate, is it Stevens-Johnson or is it staphylococcal scalded skin syndrome? And you can see how easy that distinction is, because in staphylococcal scalded skin syndrome, there was a subcorneal split because the acantholysis is involving the superficial layers, whereas of the epidermis. Whereas here you have a dead epidermis, which is right beneath the stratum corneum, an intact stratum corneum or the lacy epidermal sign. So this is Stevens-Johnson or TEN. Okay, the next things we are going to talk about, so we have talked about secondary causes. We have talked about spongiosis, we have talked about ballooning reticular degeneration, and we have talked about interface-mediated epidermal necrosis, which would be seen in bullous EM or fixed drug or in Stevens-Johnson. Now we are going to talk about true causes of an intraepidermal blister, which would be acantholysis, acantholytic dyskeratosis, and EHK or epidermolytic hyperkeratosis. So acantholysis. So what does really acantholysis mean? So for our first year residents who are in the audience today, acantholysis is a reaction pattern which refers to when this is a disease process which happens when the cells are falling apart. So this is the normal epidermis. And you can see here that the epidermal keratinocytes, they are held together by these almost invisible desmosomes. These are the little connections between the cells. That is what is holding these epidermal keratinocytes. So if something was to happen to the desmosomes, either immunologically, if there were antibodies formed against the desmosomes, or because of a genetic problem with the desmosome, you can actually see the nice desmosomes in here, then what will happen is that these cells will fall apart. So it will fall apart because the cement holding these cells is no longer there, and that will produce you this intraepidermal split, and that is acantholysis. So acantholysis is when the desmosomal connections are lost and the cells fall apart. The two diseases that produce you this pattern of acantholysis are pemphigus and Hailey-Hailey disease. Whereas pemphigus is immunologically mediated, so you will have positive DIF because there are antibodies out in circulation. Hailey-Hailey is a genetically mediated disease due to ATP2C1 mutations in the desmosomes. So that would be DIF negative. Pemphigus. So pemphigus, which is an immunoblistering disease with a positive DIF, that has your antibodies formed against the desmogleins 1, 3, desmoplakin, envoplakin, all those targeted antigens you need to memorize. Now, histologically, when you are seeing pemphigus, the split can be either in the lower portion of the epidermis or it can be in the upper portion of the epidermis. And that's how you broadly classify it. So you have pemphigus vulgaris and vulgaris-like diseases where the intraepidermal blister is in the lower portion because the split is in the lower 1/3 of the epidermis. Whereas you have pemphigus foliaceus group of diseases, which is more superficial split involving the superficial stratum spinosum and the granular cell layer. So pemphigus vulgaris-like diseases are pemphigus vulgaris and pemphigus vegetans. So we'll talk about that. And the pemphigus superficial split is pemphigus foliaceus, pemphigus erythematosus, and the endemic variant of pemphigus foliaceus, which is your Fogo-Selvagum. So the level of split is important. Now, remember I talked about IgA pemphigus. So IgA pemphigus looks exactly like your Snellen-Wilkinson disease, which is your subcorneal blister with neutrophil. So that is not your conventional pemphigus. So that's something different, and briefly just forget about it. So right now we are talking about the classic acantholytic pattern, which is classic for pemphigus vulgaris and foliaceus. Now, this is pemphigus vulgaris, wherein you get suprabasilar acantholysis with tombstoning. So the antibodies which are formed against desmoglein 3 will produce you a DIF pattern which stains in the lower 1/3 of the epidermis because that's where the split happens. And you can see that the basal layer of the epidermis is intact, and that produces you the tombstoning with the supraepidermal split. Which produces you this blister. So you have the intraepidermal blister with tombstoning, and most importantly, there is extension of acantholysis along adnexal units. So involvement of the hair follicles, the pilosebaceous units, is a very important finding in pemphigus foliaceus, which you will always see. So this is diagnostic of pemphigus vulgaris. I said foliaceus of pemphigus vulgaris. I do not pay much attention to the infiltrate in these scenarios. The dermal infiltrate often has some eosinophils, but that is not which is diagnostic of this disease. Okay, so it is the level of the split and the involvement of the pilosebaceous units in the hair follicles which will help you to diagnose pemphigus vulgaris. So this is classic pemphigus vulgaris. So we'll see some more examples of pemphigus vulgaris. So you can again see here, so this is an intraepidermal blister. The stratum corneum is completely missing. And you can see that there is nice tombstoning with suprabasilar acantholysis. There's also a hair follicle in this section, and the acantholysis is also involving the pilosebaceous unit. So that's pemphigus vulgaris. You can see that the stratum corneum has fallen apart. So it is there in the biopsy, but it is just extremely separated out, which happens in a lot of these instances. So you have to pay attention. This is another example. And you can see that here the epidermis is like completely denuded. In very subtle areas, you're able to see that the intact epidermis again shows that suprabasilar acantholysis with the tombstoning. So that's pemphigus vulgaris again. This is what the scenario in most of the cases of pemphigus vulgaris is. Most of the epidermis will be missing. Okay, so this is another example. So you can see here the nice intraepidermal acantholysis. You can have the tombstoning here. More of the intraepidermal acantholysis and the tombstoning. So that is pemphigus vulgaris. Now let's talk about pemphigus foliaceus before we talk about paraneoplastic pemphigus. So remember I said pemphigus foliaceus, when you're thinking about it, you have to think about it either as cell rich or it is cell poor. So for example, in this case, this is pemphigus foliaceus, which is cell poor because you do have a subcorneal split, but it is not very inflamed within the blister cavity. It's within the blister cavity we are talking about the inflammation. So this cell poor pemphigus foliaceus, the other differential for this would be staphylococcal scalded skin syndrome. So what you see in here, the way I always think about pemphigus foliaceus or staphylococcal scalded skin syndrome would be that the granular cell layer looks really weird. Why? Because the stratum corneum is missing, but the granular cell layers are also being involved by acantholysis, but they fall apart. So they become this hypergranular and they just look abnormal. That's your first clue. So this is your cell poor subcorneal blister with acantholysis involving the granular cell layer and the superficial stratum spinosum. So without any clinical hint, this could be either. This could be staphylococcal scalded skin syndrome or it could be pemphigus foliaceus. And those are obviously easy diseases to distinguish clinically, and also DIF positive versus negative. Positive would be pemphigus foliaceus and negative would be staphylococcal scalded skin syndrome. This is the other kind of pemphigus foliaceus, which is a cell-rich variant, which tends to mimic bullous impetigo. So you can see here, there is a subcorneal blister, but it is very inflamed. It has all this neutrophilic infiltrate in it and without the bacteria. So this could be either, right? This could be either bullous impetigo or it could be pemphigus foliaceus. So you will have to look at a certain amount of hint to determine what this entity is. Without if they don't have that distinction, then there should be either one of the two answers. It could either be pemphigus foliaceus or it could be bullous impetigo. This is the cell-rich variant of pemphigus foliaceus. Okay, now I'll show you another example of pemphigus foliaceus. Pemphigus foliaceus can also involve the hair follicles. It almost always does. If you have the hair follicle in the section, look for the subtle involvement. So you can see here, this is beautiful pemphigus foliaceus. There is a subcorneal split in here, and you can see how it is involving the granular cell layer of the follicular infundibulum. So it just looks abnormal. When the stratum granulosum is involved and the cells fall apart, they just look abnormal because they are hyperchromatic and they fall apart. So this is pemphigus foliaceus involving the hair follicle. Okay, the next entity which we're going to talk about is an entity which is a very important board question. If it is present, it is a question which not everybody can answer. So if you get it, you're definitely on the right track, doing a great job. It's an easy entity, however, to recognize because not many diseases produce this, and that is pemphigus vegetans. So you know what it is. So pemphigus vegetans, clinically, you will never think about a blistering disease because these patients present with hypertrophic vegetative plaques, which are often in intertriginous sites. The histology finding of this always includes these findings, which are classic for this disease, which would be number one, you will get a hyperplastic epidermis, which is what is producing the vegetative appearance clinically. But most importantly, you get the presence of eosinophilic microabscesses. So these collection of eosinophils forming a microabscess in the epidermis. And you have talked about diseases which have eosinophils in them, but really not many diseases do that. Even rarely bug bites will also do that. This is a very important finding, this collection of eosinophils in the epidermis forming a microabscess with epithelial hyperplasia. That's the first clue that you are likely dealing with something like pemphigus vegetans. The next clue would be the fact when you, and this may not be present in all instances, it may be present, may not be present, is a plasma cell infiltrate. The plasma cell infiltrate happens in the biopsy because of the location, because this is intertriginous site. Often plasma cells are seen in those sites, but it is not a part and parcel of the disease. It may not always be present. But then you will pick up on the subtle acantholysis. So when you see a vegetative plaque, which is epidermal hyperplastic, epidermal hyperplasia, along with an eosinophilic microabscess, you have to go back into the biopsy and look for subtle areas of suprabasilar acantholysis, which is what you see in over here. So you can see the subtle split in the epidermis. This is all suprabasilar acantholysis. And those three findings will be diagnostic of pemphigus vegetans. So let me show you another slide of pemphigus vegetans. So you can see here the epidermal hyperplasia, the eosinophilic microabscesses. This is again classic, this kind of a ball of collection of eosinophils in the epidermis. And then once you notice these two findings, you will see the nice suprabasilar acantholysis. Hold on. So you can see here the nice suprabasilar acantholysis in here. So the suprabasilar acantholysis, the epidermal hyperplasia, and the eosinophilic microabscesses. So the triad of that is consisting with pemphigus vegetans. Do you guys have any questions? Okay, so the next disease we are going to talk about is paraneoplastic pemphigus. Now, paraneoplastic pemphigus is a really favorite board entity that they love to test you on. That's because there is a lot of things that can be asked regarding it. Guys, I'm going to quickly take this call. Give me a minute. Hey, Elise. Oh, no, you're good. I'll call you. I'm teaching. Okay, bye. So, paraneoplastic pemphigus. So this is something which, there are plenty of second order questions they can ask you. So my strong advice to you for today is go back and read about paraneoplastic pemphigus. Now, all of you know it presents with intractable stomatitis. So oral involvement is classic. It presents with features which are not classic for your classic pemphigus. So like, for example, involvement of the acral sides, the dorsal aspect of the hands. It has kind of like a polymorphous clinical presentation. So it can mimic lesions of erythema multiforme or bullous pemphigoid. And obviously it's paraneoplastic association. So association with interesting tumors like thymomas or with your Castleman's disease and with even hematopoietic tumors or carcinomas. So, so that's why a lot of questions can be asked, and then it's, the DIF findings. So you want to go ahead and memorize that. Now, when do we think about it under the microscope? We think about it when we are seeing acantholysis, which has the pattern of pemphigus vulgaris. So you can see the suprabasilar acantholysis, but then we also see erythema multiforme pattern with vacuolar alteration and necrotic. So it's a combination of pemphigus vulgaris and erythema multiforme. So you can see here the nice acute stratum corneum, the vacuolar alteration, and then the death cells present in the varings layer. So this is the erythema multiforme-like pattern in combination with your suprabasilar acantholysis. So that's when you think about paraneoplastic pemphigus. So remember, pemphigus vulgaris-like pattern with EM-like pattern is paraneoplastic pemphigus. So this is again, it's a very, it's a high-level derm path question. If they ask you at this level, then if you're getting it, then you're doing extremely well. but it's more of a, a dermatopathology fellow board question, but you should know about it. Okay, well, that was about your pemphigus group of diseases. Now let's go to your the other group of diseases which are non-immunoblistering but also present with acantholysis, which is Haley-Haley disease. Haley-Haley disease, the other name of it is benign familial chronic pemphigus. This can be very challenging to distinguish from pemphigus vulgaris, but obviously its clinical presentation is completely different. And it's not immunologically mediated, so this will be DIF negative. The classic histologic finding is the dilapidated brick wall appearance, which is your incomplete acantholysis. So in the background of complete acantholysis, where you see the tombstoning, which looks indistinguishable from pemphigus vulgaris, you will see these areas of incomplete acantholysis where the cells are falling apart, but they have not yet fallen apart. So they're still holding hands. It almost looks like a brick wall, which is kind of falling apart. So this is the classic finding. The other thing would be the sparing of adnexal unit. So it doesn't involve the hair follicle. So unlike pemphigus vulgaris, which goes down the hair follicle, Haley-Haley disease will spare the hair follicles. This by far is going to be really the most important distinguishing feature. Again, I do not rely on the degree of the dermal infiltrate and other findings like the presence or the absence of eos for recognizing this entity. It's another example of Haley-Haley disease. You can see the incomplete acantholysis or the dilapidated brick wall appearance. Show you another example. It's another example of Haley-Haley disease. You can see this is a nice dilapidated brick wall appearance right there. So that would be Haley-Haley disease, incomplete acantholysis. The next reaction pattern we're going to talk about is acantholytic disc keratosis. So acantholytic disc keratosis is the reaction pattern that you see in Darier's and in Grover's disease. This reaction pattern produces the findings of core rons and core grains, which are, diagnostic. So once you recognize the core rons and core grains, you know that you're dealing with either Darier's or Grover's disease. So what is acantholytic disc keratosis? In acantholytic disc keratosis, the cells are not only falling apart, but they're also becoming dyskeratotic. So they're also becoming necrotic and pink. And this produces two types of cells, which are core rons and core grains. So core rons are the cells which will have this halo around them. So all of this particular cell, these are the core rons. So you can see these nice kind of perinuclear halos. They're often seen in cells involving the granular cell layer. So a dense nucleus and a perinuclear halo. Whereas the core grains are these grainy cells, which almost look like necrotic cells, but they have fallen apart. So they look like little grains with dense pink cytoplasm and dense blue nucleus. So this is the core rons and the core grains. When you see this, you're dealing either with Darier's disease or with Grover's disease. Again, Darier's and Grover's disease can look indistinguishable from one another. So what are the findings that you are going to use to distinguish between these entities? Remember that Darier's disease, the other name of it is keratosis follicularis. So again, the involvement of the hair follicles would be an important finding. So if you see a hair follicle which has been involved, that is going to be your Darier's disease. If you see absence of follicular involvement, that would be Grover's disease. Also, Grover's disease is a papillary eruption. Obviously, the clinical is completely different, right? Grover's disease is an itchy papillary eruption on the trunk of an elderly individual. Whereas Darier's disease, more younger patients, seborrheic, acral, intertriginous sites can be involved. Often the lesions can be background, impetiginized, and obviously the presence of involvement of hair follicles. In general, if I see tiny papules which are separated by normal epidermis, then I think about Grover's disease if there is no clinical hint. But if I see confluent hyperkeratosis and confluent acantholytic disc keratosis, then I think more, especially with follicular involvement, then I'll think more about Darier's disease. Like in a biopsy like this, it's very difficult to distinguish. Is this Darier's or is this a Grover's disease? So there should be some hint. But it is one of the two because you see the core rons and the core grains. So these are the core grains right here, and these are the core rons here. And this is the reaction pattern of acantholytic disc keratosis. I'll show you more examples. So again, you can see in here, this is again in acantholytic disc keratosis. You can see all of these are the core rons in here, the core rons, and you can see the core grains in here. So again, this would be very difficult. Is this Darier's disease or is it Grover's disease? Remember segmental Darier's disease, which can be Blaschkoid in distribution, linear in its presentation, and with a somatic mutation, which involves the ATP, what is it, ATP2A1 genes, but not in a genetically predisposed pattern. So it could occur. So that would be more of a linear presentation. And this is how we often see it, and it is indistinguishable from Grover's disease. But again, there is nothing on histology that you can diagnose. You have to have a clinical hint for diagnosing that entity. On the other hand, something like this. If you get a biopsy like this, now this is more diagnostic of Darier's disease because you can see the confluent hyperkeratosis. There is follicular involvement, and you're seeing this marked acantholytic disc keratosis with numerous codons and code grains. So this is a hair follicle. It is involving the acantholytic disc keratosis. Is involving that structure, background marked hyperkeratosis. So this is something where they can, yes, you would be more easily be able to recognize this to be Darier's disease without the clinical. So that's Darier's versus Grover's disease. But otherwise, honestly, the distinction can be very challenging just based upon your microscopic findings. This is another example. This is an example of a patient with Grover's disease. This is easy because you can see there is a tiny small papule. The background, it looks pretty like non-involved, and you have just one papule. Often the infiltrating Grover's disease will have eosinophils, but again, I do not really rely on that for distinguishing it from Darier's disease, because you can have some eos even in the infiltrate of Darier's disease. This is a nice acantholytic disc keratosis. There is a codon here, and you can see the code grains in here. Now, acantholytic disc keratosis as a reaction pattern can also be seen in solitary entities. So the solitary disease entities that do that are your wadi disc keratoma and acantholytic acanthomas. So wadi disc keratoma is a solitary papule which presents on the head and neck. I never call something a wadi disc keratoma which occurs outside the head and neck. The classic location of it is the forehead, the temple, even the ear involvement can occur. Clinically, you're off thinking about a squamous or a basal cell when they get biopsied. And histologically, this is an endophytic papule. So it looks warty on the top, and then there is this endophytic invagination, and the lesion is very well circumscribed. So you can see that even though it will be an elderly patient, there is not often a whole lot of sun damage. Very well circumscribed lesion and endophytic proliferation. And the endophytic nodule has this codons and core grains with the acantholytic disc keratosis. So you can see the nice core grains and the codons. So this is the reaction pattern of wadi disc keratoma. It will look like a wart on the top with an endophytic nodule, which is well circumscribed, showing the codons and the core grains. The same thing, if it occurs outside the head and neck, that's when I call it an acantholytic acanthoma. Very often you can get acantholytic disc keratosis as a solitary lesion. So that is referred to as solitary acantholytic keratosis, incidental finding, mimicking a malignancy, but it is completely benign. So this is wadi disc keratoma. Because of its architecture and location, that's how we diagnose it. This is another example of a wadi disc keratoma. You can see here, you can nicely see it's a solitary lesion, very well circumscribed, has verrucous proliferation on the top, and then you have this endophytic nodule, which has a beautiful codons and core grain. So that's a wadi disc keratoma. The next reaction pattern, which we are going to talk about, is your epidermolytic hyperkeratosis, or EHK. So epidermolytic hyperkeratosis, or EHK, is a reaction pattern which happens because of the involvement of the intracytoplasmic keratin filaments. So and it always produces these findings. There is marked hyperkeratosis and hypergranulosis with the pallor of the stratum spinosum. So the stratum spinosum looks really pale. This pattern of hyperkeratosis and hypergranulosis mimics a wart. So when you look at it on low power, the first thing you always think about is this a wart? But it's not, because in a classic wart, you do not get pallor of the stratum spinosum. So you do get hyperkeratosis with prominent keratohyalin granules. So that's something, the similarity with the verruca. But you do not get the pallor of the stratum spinosum, along with intracytoplasmic dissolution of the keratin filaments, which produces this pink cytoplasmic inclusion. So you can see these pink inclusions inside the cytoplasm. Because the problem here is the intracytoplasmic keratin filaments, keratin 1 and 10, which are clumping together to produce this pallor of the stratum spinosum. Accompanying this is the acanthosis and the hyperkeratosis and the hypergranulosis. But the pallor with the pink cytoplasmic inclusions is classic for all these pink inclusions are classic for EHK. When you deal with EHK, this is again the chart that you have to memorize. So it could be incidental. You could see it in a variant of an epidermal nevus. You can see it in a blistering eruption in the kids, which is congenital bullous ichthyosiform erythroderma, or a localized eruption, which is ichthyosis bullosa of Siemens. So you need to memorize what keratin mutation is involved in what. And you can also see it in palmoplantar sclerodermas, the epidermolytic one, which is your Warner syndrome, which is keratin 1 and 9 mutation. So when they show you this particular reaction pattern, they will always ask a second order question with this. So this is a reaction pattern of epidermolytic hyperkeratosis. Okay, now let's talk about a friction blister. So friction blister is easy to recognize. It's a very commonly asked board question. Your phenobarbital poisoning in a comatose patient. It's not something that we see a lot, but it is a nice board question. They like to test you on it. What you see in a coma blister is that the epidermis will look like the lacy epidermal sign of EM major or Stevens-Johnson syndrome. So it's the dead epidermis juxtaposed beneath an intact stratum corneum. It's often a cell-poor blister, but the hint for diagnosing the coma blister is to look at the sweat glands. So there are not many entities out in derm paths which will produce you sweat gland necrosis. So if the top looks like the lace epidermal sign of EM major or Stevens-Johnson accompanying the sweat gland necrosis, that's when you will think about a coma blister. Okay, then let's come to your friction blister. Friction blister is a very non-specific blister. It is traumatically induced. So it will occur on sites which are easily prone to trauma. So like the knees or the back of the hands or like the feet. And the level of the split does not make sense. So it is neither subcorneal, neither subepidermal. It's somewhere right in the middle of stratum spinosum. It is cell poor. There is often organizing hemorrhage and thrombosis. So it literally looks like a tear in the skin, which does not make sense. That is your friction blister. And then lastly, remember herpes virus infection. Herpes virus is notorious for producing you intraepidermal blister with a lot of inflammation. So if you see a slide which is extremely busy, has intraepidermal blister along with inflammation, and the inflammation could be deep, it could be perifollicular, and the acantholysis can be subtle. So you often see cells falling apart in the blister, but to diagnose it to be herpes virus infection, you have to see the viral inclusions, which is the 3 M's. And the 3 M's are multinucleation, nuclear molding, and margination of chromatin. So you see a big cell here, which has multiple nuclei, so multinucleation. These nuclei are sticking to one another, which is nuclear molding, and you have this margination of chromatin. So the nucleus actually looks cleared out like a glass. So nuclear clearing looking like a glass, multinucleation, and nuclear molding. So these 3 M's is classic for herpes virus infection. And you need to see this to be able to diagnose it. And remember that these viral inclusions are non-specific, right? Because you can see them in HSV1, HSV2, varicella, chickenpox, zoster, shingles. So all of them will produce the same reaction pattern. So that is your herpes infection. So that was about your intraepidermal blistering diseases, and we are going to now go into the subepidermal blistering diseases. Do you guys have any questions as of now? And I'm going to share this presentation with you all at the end of this class, and so you can go back through the theoretical part of these questions, of these slides. Okay, so any questions? Okay. So now let's go to your subepidermal blistering diseases. So when you are looking at a subepidermal blister, it's the most easily recognizable blister, right? It's a blister right beneath the epidermis. The approach to it is what you need to memorize. The first thing to look at it is it cell poor or cell rich? And this distinction is absolutely important. So what do you mean by cell poor? Cell poor means there is no inflammation, but blood doesn't count, okay? So hemorrhage is often seen. and it could be procedural. So without the blood, if there is no inflammation, with or without the blood, if there is no inflammation, it is cell poor. But if you do see inflammation, it is a cell-rich subepidermal blister. This distinction is important because when you're dealing with the cell-rich blister, then we're going to talk about all these diseases. So forget about this right now. Let's talk about a cell-poor subepidermal blister. When you're talking about a cell-poor subepidermal blister, these are the diseases that you need to memorize. So I do want you to memorize all these 6 diseases. The other way of remembering it is, it's a cell-poor subepidermal blister, which could be either DIF positive or it could be DIF negative. So this is how I remember it. It's a cell-poor subepidermal blister. Is it DIF positive? Is it DIF negative? If it's DIF positive, it could be EBA, porphyria, or pseudoporphyria. And if it's DIF negative, it could be the inherited epidermolysis bullosa group of diseases, which includes simplex, junctional dystrophic, and hemidesmosomal. The most important is the dystrophic. So in adults, this is what you will see, the EB dystrophic variant, which mimics EBA. Or it could be bullous diabeticodum and cell-poor subepidermal blisters induced by drugs like NSAIDs. Okay, so this is a very important slide to memorize. So let's look at some slides of your subepidermal blistering diseases. So this is an example of what we just talked about. This is your subepidermal blister. Remember that hemorrhage doesn't count, and you're looking specifically for inflammation within the blister cavity. And this has got no inflammation whatsoever, so this is a cell-poor subepidermal blister. Now, look at your question. What are they asking? Is there a clue, or they have only one of these listed entities in there? So any of these entities could look like that. So you have to look for a second order question, which could be a DIF question. It could be a clinical question. So you have to make sure what are they asking, because all of these entities will look like this. It's a cell-poor subepidermal blister. However, if you get a cell-poor subepidermal blister with scar, so like for example, in here, if I get a cell-poor subepidermal blister with scar, now remember, whenever there is a scar, the scar may have inflammation. Okay, so it may your eyes may think that this is a cell-rich blister, but it's not. So it is important to recognize the scar. This is actually on acral skin, and you have a cell-poor subepidermal blister with hemorrhage, which has a little bit, which is organized, and you have a dermal scar. So let me show you another example. This is a very classic scenario. We deal with this quite a lot. You have a subepidermal blister, and sometimes a cell-poor subepidermal blister, your eyes may ignore it. You may think it's an artifact. Don't ignore it. It is a true subepidermal blister, and you can see that there is scar, and this is milia. So there is subepidermal blister with scar and milia formation. This is a very common presentation for EBA or porphyria or pseudoporphyria and for dystrophic epidermolysis bullosa. So when you see something like this, cell-poor subepidermal blister with scar plus and minus milia formation, these are the diseases that you think about: EBA, porphyria, pseudoporphyria, and dystrophic EB. Okay, so this is what you need to memorize. And this is how it will look like. This is not uncommon. This is very commonly encountered. We will get something where the blister is, you ignore it because your eyes just catch the scar and the milia. Notice its location on acral skin. Notice the subepidermal blister, the scar and milia formation. And then you're thinking about EBA, porphyria, pseudoporphyria, or dystrophic EB. Okay, so those are all the questions that can be asked. Now, what is the caterpillar body and the festooning, which is talked about a lot? Now, the festooning and the caterpillar bodies, honestly, I'm just going to talk about it because you need to know about it because it's mentioned a lot in the dermpath books, but they are non-specific findings, which we often see in subepidermal blisters, and especially in cell-poor subepidermal blisters, because they're obviously seen because there's not a whole lot of inflammation. So the festooning of the dermal papilla is when the blister, the base of the blister, it kind of protrudes into the blister cavity. And the caterpillar bodies are these eosinophilic fibrinous structures which are hanging off from the roof of the blister. These are non-specific findings, and they can be seen in any of your cell-poor subepidermal blistering diseases. So, I do not pay much attention to those particular findings. One of the things which is often seen, so all the entities which we talked about in the cell poor subepidermal blisters are pretty much, not distinguishable from each other without, the DIF or without a second order question associated with them. However, there is one clue to porphyria and pseudoporphyria. So that would be, first of all, dislocation on acral skin, a cell poor subepidermal blister, which invariably is very hemorrhagic for some reason, but it is cell poor. And the base of the blister cavity has all these halonized vessels. So if you see thick walled vessels in the blister base, it makes you think about porphyria or pseudoporphyria. And this is exactly what the DIF targets as well. So the DIF will actually show you the donut vessels. This is where the immunoreactants are getting deposited. Now, remember that porphyria and pseudoporphyria have the same exact histology and DIF findings. The only way to distinguish between porphyria and pseudoporphyria is by doing serum and urine porphyrin studies. Otherwise, those diseases can exactly be identical. And remember, however, they occur in different clinical scenarios. So the associations with pseudoporphyria, you guys need to remember. There's so many second order questions that can be asked, and that is why it is a very, very high yield board entity. This is all the perivascular halonization noted of the vessels in the blister base. That's porphyria or pseudoporphyria. Okay, now let's talk about a cell-rich subepidermal blister. So when you have a cell-rich subepidermal blister, the way to deal with it, this is pretty clear-cut for your board purposes. It's not that clear forward in real life. In real life, we have a lot of overlap. But for your board purposes, if you have a cell-rich subepidermal blister, you see if does it have eosinophils or does it have neutrophils. If it has eosinophils, it is bullous pemphigoid, or anything which has the name pemphigoid in it. It could be cicatricial pemphigoid, it could be pemphigoid nodularis, it could be the bullous pemphigoid in pregnancy, which is pemphigoid gestationis. Anything with the word pemphigoid has eosinophils. And if it is neutrophils, and you're thinking about these 4 diseases, dermatitis piriformis, linear IgA disease, bullous lupus, and chronic bullous dermatosis of childhood. Bullous lupus is very different from the classic lupus, which we talked about in your interface diseases. So that is very different. That has a complete different histology as compared to the bullous lupus, what you're seeing in here. The bullous lupus in here has no interface change. It really looks indistinguishable from linear IgA disease, and we'll talk about that. Okay, so bullous pemphigoid. So obviously bullous pemphigoid is like an absolutely essential board question. It's definitely going to be there. And it's an easy diagnosis. I rarely encounter that you guys struggle with it. It's a cell-rich subepidermal blister. An important thing to recognize is that the blister cavity has this fibrinous degenerated debris. Sometimes you ignore that. That can be a clue for bullous pemphigoid. This kind of a pink fluid in the blister cavity. And once you go in the blister cavity, you will see lots of eosinophils and also eosinophils in the base of the blister. Remember that a long-standing blister can undergo secondary necrosis. So you can see that the roof of the blister in here has started to produce you that artifactual lacy epidermal sign. That is why it is nice to back and look at the whole slide. You should not see this degenerated debris with a ton of eos in the blister cavity in bullous EM or Steven-Johnson. So that would be important. So this is a cell-rich subepidermal blister with this pink fluid in the blister cavity and a lot of eosinophils. Let's see another example. So you can see here the cell-rich subepidermal blister. Again, the same fibrinous debris within the blister cavity, this kind of fluid-filled debris and tons of eosinophils. Cicatricial pemphigoid Brunstring Perry disease would also be the same, except that background scarring is often seen. So it is a more localized variant of BP. It will look exactly the same. It may be a little bit more clinically challenging to diagnose because very often this will mimic non-melanoma skin cancers, especially when they're occurring on the head and neck region, which is like the more common site. And you will see a subepidermal blister. Again, there will be eosinophils, but there is often background scarring. So it looks more like a chronic blister. Prodromal phase of bullous pemphigoid is also a really important board question. In prodromal phase of BP, you lack a frank subepidermal split, But what you see is a band-like infiltrate with eosinophils, and the eosinophils are often seen lining up along the dermoepidermal junction. So you can see in here, it overall looks like a very quiescent biopsy, but it's not. When you pay attention, there are a lot of eosinophils in the infiltrate, and all the eosinophils are almost localized in the top layers of the epidermis. A very nice clue is eosinophilic spongiosis. So when eosinophils start coming up into the epidermis, so you can see that the eosinophils are coming up in the epidermis and they're lining up along the DE junction. That's a very nice, so you can see here a nice eosinophil at the dermoepidermal junction. In general, when you see eosinophils in the skin, you're thinking about A, B, C, D. A stands for arthropod assault, B stands for bullous pemphigoid, C stands for contact derm, and then D stands for like any drug reaction. In arthropod assault, you would expect to see a much more deeper eosinophilic infiltrate. In contact dermatitis, you would expect to see much more degree of spongiosis with that degree of eosinophilia. So, so it's neither that deep, neither very wet. So because of that, that's what makes you think about prodromal BP. And especially this clue, when you see the eosinophils lining up along the DE junction, that's pretty, pretty classic. You should always, whenever you see in a biopsy eosinophils lining up along the DE junction, I always worry about prodromal BP. So that's prodromal phase of bullous pemphigoid. The next one is going to be dermatitis herpetiformis. This is an itchy disease, presents with a papular excoriation. Often in the biopsy, you may miss the blister, so it is not infrequent to just see ulcer secondary to excoriation. So if you keep on biopsying and you keep on getting ulcer secondary to excoriation, you still pursue your attempt. And always, when you're thinking about DH, please do a DIF. You have to do a DIF. The other thing is that in the absence of this kind of a blister, the background dermal changes can look very much like papular urticaria. So the eosinophilic infiltrate, the nice perivascular infiltrate, so all that can be very distracting. But to diagnose DH, you have to see the nice subcorneal blister, which is this collection of neutrophils at the tips of the dermal papillae. This is pretty diagnostic of DH when you see these neutrophils collecting at the tips of the dermal papillae. And this is where your IgA collection also goes. So you see collection of, the IgA at the tips of the dermal papillae. So this is diagnostic for dermatitis herpetiformis. This disease can have a very varied presentation in elderly individuals. So, definitely when you're thinking about this and the biopsy is non-specific, do consider doing a DIF. And the serology studies, they are not like, you cannot use them in lieu of a DIF. The diagnostic is the DIF. So this is a nice subcorneal blister with neutrophils. One thing which I do want to tell you is, and I will reinforce this later when we are doing vascular diseases, that one entity which can produce this subcorneal blister with neutrophils is leukocytoclastic vasculitis. So if you are in a hurry, and you see something like this and you do not pay attention to the vessels, I promise you, you will miss an LCV. So we will talk about this when we are doing LCV. So that sometimes LCV can produce this collection of neutrophils at the tips of dermal papillae, which looks exactly like DH. So before you're diagnosing dermatitis herpetiformis, please make sure that you're looking at the vessels and you're not missing a leukocytoclastic vasculitis. Okay, so this is DH, again, this nice neutrophilic collection at the tip of the dermal papillae is diagnostic of DH, and often there is an ulcer secondary to excoriation. The next one is going to be linear IgA disease and bullous lupus. These entities are indistinguishable based upon just your histology. It's often a linear split. It's a subepidermal split with the blister cavity, which again contains this pink fluid, which is similar to what you saw in BP. But the infiltrate is different. The infiltrate is predominantly neutrophilic. This does not mean that you're not going to see any EOs. This is always the confusion that I get. You may see a couple of EOs, but the predominant cell is a neutrophil. And that's why it becomes important for you guys to recognize, are they truly neutrophils or eosinophils? So every cell that I'm seeing in over here is a neutrophil, is not an eosinophil. There are some extrabasated red blood cells, but there is no eosinophil in this particular infiltrate that I see over here. Maybe this may be one eosinophil right here, but all of these cells, and these have all. So eosinophils have prominent orange granules, and neutrophils have prominent, they look like ants. They have multi-lobed nuclei. So, make sure that you are recognizing the right cell, because that will be the only distinguishing feature between BP and linear IgA or in bullous lupus. Again, linear IgA and bullous lupus will look exactly similar. The only way to distinguish them is the DIF finding. The DIF will show linear IgA deposition in linear IgA disease. And in bullous lupus, it's a full house. It's classic to lupus, where you get coarse granular deposition of multiple immunoreactants in the epidermis, in the dermis as well. So that is linear IgA and bullous lupus. And chronic bullous dermatosis of childhood, which is a variant of linear IgA which occurs in kids, also looks exactly similar. And then lastly, don't forget entities like lichen planus. They can definitely produce you a Max Joseph space, which can mimic a blistering disease. Always in bullous LP, you will see that wherever the blister has occurred, at the base of the blister, there will be band of inflammation. And then adjacent to the epidermis, also, you will see this band of inflammation. That's bullous LP. This is not similar to lichen planus pemphigoides. That's a completely different entity. That is an entity which is truly overlapping features of lichen planus and bullous pemphigoid. Okay, so it is not blistering LP. It is truly LP and BP, both those entities in the same patient. So lichen planus pemphigoides is not bullous LP, and it will not show. In lichen planus pemphigoides, the lesions will be either LP or bullous lupus, a bullous pemphigoid, based upon what you biopsy. So that brings us an end to the blistering diseases. You guys have any questions?
I have a question. How do you can you tell, like, if, for example, in the coma bolus disorder, the gland is necrosed?
Say that again for us.
You mentioned that in coma blisters disorder, the gland
in coma
is
blisters. Yes.
Yes, the gland is necrosed.
Yes.
So I want to know, like, how can you tell it's necrosed versus a normal, like, what do you see, like, you can tell
Okay,
it's
so let's go back to that slide. So in this one, this is almost like a normal sweat gland, but these are all necrotic. So in necrosis, you will see kind of like secretions within the lumina, which will look like secretion, but they're actually all desquamated, dead necrotic cells. And you will see debris and a neutrophilic infiltrate. So you will see apoptosis, you will see nuclear debris. They will just look dirty, whereas this is a normal looking sweat gland. This is a normal looking sweat gland, and this, you can see the pale. So this is extreme necrosis. So this is normal, extreme necrotic, and early necrosis.
Thank you.
Normal, extreme necrosis, early necrosis. Any other questions? I know this is a lot to take in. You have lots of studying to do, lots of memorization of slides. To me, blistering diseases is almost like a mathematic analogy. The more you look at it, the more you will remember it. But, it's nice because there are some formulas and there are certain tables that you need to memorize. So I'm going to share this with you guys, and please take a moment today. It's fresh in your memory to memorize these, and it becomes more clearer when we will go through your multiple choice, when we'll go through, some of the study sets. Any other questions? Okay, so the Goodman residents can log off, and I'm going to briefly talk with the others. Thank you, guys.